Thank you, Mike, for the introduction. I witnessed the birth of OHBM in 1995 in Paris, and then its naming after a somewhat contentious debate in Boston in 1996. And then I had the privilege of serving in council for quite a number of years as head of the program committee and then as chair of council. Then there were distractions that came in, and I haven't been to an OHBM meeting for, I think, about 10 years. But I must say that it really still feels like home. So, Mike, thank you very much for this really very special invitation. So I thought that I would make use of this opportunity to tell you parts of a long story related to a region of the human brain known as Wernicke's area. As you know, there was a time when language used to be simple. So we had Broca's area, where damage gave rise to loss of fluency. We had Wernicke's area, where damage gave rise to loss of language comprehension. And then we had the arcuate fasciculus, which connected the two, and where damage gave rise to conduction aphasia. This classic model was based almost entirely on patients with focal cerebrovascular lesions. So today I'm going to tell you about a completely different type of language disorder caused by a neurodegenerative syndrome known as primary progressive aphasia, which is prompting us to rethink this classic model, especially as it relates to Wernicke's area. The story that I'm going to tell you starts in 1874 in Breslau, where a young neurologist called Wernicke published this monograph. By 1874, most neurologists were quite familiar with Broca's aphasia, where damage to the left inferior frontal gyrus gave rise to loss of fluency and grammar, but didn't interfere with language comprehension. In this monograph, Wernicke was describing something completely different. His case 2 was that of Suzanne Rotter, who was admitted at the age of 75 with an acute change in mental state. So at admission, her fluency was intact, but she could not understand language or repeat words that she heard, although she was not deaf. A few months later, the patient died, an autopsy was performed, and Wernicke observed a softening of the left superior temporal gyrus, and he reached this conclusion. He said, therefore, we may state with some confidence that the only cerebral lesion which might have produced the persisting aphasia was the softening of the superior left temporal gyrus. And this conclusion was accompanied by this diagram where you may be able to identify the small letter A, which denotes the ending of the acoustic nerve, damage to which presumably caused Rotter's inability to understand and repeat words that she heard. There's no question that Wernicke was a great neurologist, but looking at this drawing, you wonder if he had equally well-developed artistic skills. This diagram looks more like the brain of a cat than a human brain. And of course, this is the wrong hemisphere. It's the right side of the brain. So either in 1874, Wernicke suffered a transient episode of Gerstmann syndrome, or else his publisher dropped the ball. But all of this was resolved in the pages of Wernicke's monumental 3-volume textbook of neurological diseases, published in 1881, where here Y indicates the lesion site for Broca's aphasia, and X indicates the lesion site for Rotter's inability to understand and repeat words that she heard. And this is an area that over time came to be known as Wernicke's area. Now, in contrast to Broca's area, which led a sedentary life in the inferior frontal gyrus for 150 years, Wernicke's area has had a tendency to wander. And let me try to reconstruct this for you. I have put a red asterisk at the foot of the central sulcus in all of these diagrams for the purpose of orientation. So this is Wernicke's 1881 diagram. You see his area covers the middle third of the superior temporal gyrus. Then, a few years later, for reasons that are entirely unknown, Desjardins decided to push Wernicke's area completely behind the central sulcus. Translocation that was explicitly endorsed by Wernicke in his last major work on aphasia, published in 1906 after his death. But then, in the ensuing decades, the movement became popular to incorporate Desjardins' visual word association area into Wernicke's area. So Wernicke's area now contained the entire inferior parietal lobule, together with a generous helping of the middle temporal gyrus. This expansion was endorsed by giants of neurology, such as Charcot, Murray, Critchley, Lermite, and so on. But there was more to come. In their influential book on aphasia, Penfield and Roberts decided to take away much of the superior temporal gyrus from Wernicke's area, but as a consolation prize, gave it the inferior temporal gyrus. And this, on the right side, is the most inflationary map of all. That's where I have drawn the boundaries of a Wernicke territory, which contains all the components I could find in the literature that had ever been suggested to be parts of Wernicke's area. So today, in June of 2017, essentially all textbooks of cognitive neurology and neurology would lead to the expectation that damage to this area should give rise to the most severe word and sentence comprehension impairments that one can ever see in neurological patients. This is the expectation that my colleagues and I decided to test in a set of 72 patients with primary progressive aphasia, consecutively enrolled in a longitudinal study. As you may know, primary progressive aphasia is a syndrome where a neurodegenerative disease causes a progressive and initially isolated language impairment. This is an atrophy map of PPA compared to normal controls. And here you see the biological hallmark of PPA, as in other words, the asymmetric neuronal loss or atrophy in the language-dominant left hemisphere of the brain. And according to the current Gorno-Tempini criteria for classification, 25 of our patients had agrammatic PPA, 21 semantic PPA, 12 logopenic PPA, and 14 were unclassifiable. All patients were given the same tests of comprehension, naming, and repetition, and the range of performance in this set of 72 was broad enough that it included those who had severe impairment and those where these factors were completely preserved. For word comprehension, the subject would hear a word and then would have to point to the corresponding picture. And for sentence comprehension, the patient would be asked to point to the boy who the girl is kissing, for example. And in this sentence comprehension task, the single words were simple enough that they were understood by all patients, and performance depended not on word comprehension, but on the ability to decode the syntactic structure of the sentence. So the first thing we wanted to find out is whether patients with neuronal loss in Wernicke's area had impairment in these comprehension tests. So we first looked at individual atrophy maps in all 72 patients and chose those where the atrophy was pretty much confined to Wernicke's territory without encroachment on Broca's area. This is an atrophy map of the 7 such patients. And you can see that severe neuronal loss infiltrates the entire extent of even the most inflationary rendition of Wernicke's area. When we looked at performance, however, the impairments came nowhere near what we would expect to see in patients with Wernicke's aphasia. Word comprehension was essentially intact. Sentence comprehension was variable, modestly impaired in some, intact in others. Same pattern occurred in object naming. The one most consistent impairment was seen in repetition, which is consistent with current thinking, suggesting that the temporoparietal junction here plays an important role in maintaining the integrity of the phonological loop. Furthermore, in the set of 10 patients with the worst sentence comprehension, we found, in 5 of these, we found no detectable atrophy in Wernicke's area. So we have to conclude that atrophy in Wernicke's area is neither necessary nor sufficient for impairing word or sentence comprehension. So at this time, having concluded that damage to Wernicke's area does not cause Wernicke's aphasia, we wanted to find out those parts of the brain that did play a critical role in comprehension. So we ran a simple regression analysis to look for those areas where the amount of cortical thinning was correlated positively with the degree of impairment in these comprehension tasks. And these are the results. On top are the correlations with sentence comprehension impairment, and you can see that there are significant correlations with the posterior parts of Wernicke's area, but also with large extent of lateral frontal cortex, including Broca's area. So we can conclude that while the posterior parts of Wernicke's area influence sentence comprehension, that they are not critical for this function, and that the substrate of sentence comprehension is very widespread in the left hemisphere. A different picture emerged when we looked at the correlations for single word comprehension. Here, the significant correlations were pretty much confined to the anterior temporal lobe. And 8 of the patients with the worst single word comprehension scores had detectable atrophy only in the left anterior temporal lobe. So we can conclude that the left anterior temporal lobe is the critical correlate of severe word comprehension impairments. One of the most important outcomes of this analysis is to show that there's no overlap between areas that are critical for sentence comprehension and areas that are critical for word comprehension. So it seems as if the human brain doesn't have any single area where neurons are equally critical for word and sentence comprehension. So, does this mean that Wernicke's area doesn't exist and that Wernicke's patient was fictitious? There are some who thought so. The first part of our paper was published online at the evening of June 24, 2015 by Oxford University Press. A few hours later, at 5 a.m. Eastern Standard Time, this news item was posted in the motherboard site. And then 4 days later, Le Monde, which is not known for fake news, announced the demise of Wernicke's area. So obviously, we were very flattered by this attention that our paper received, but I'm not sure I quite agree with the results. I think there is a way to reconcile our findings with classic aphasiology if one takes a close look at connections. These are connections of Perisylvian language areas from the beautiful atlas of Marco Catani and Thibaut de Chaudon. And here I have indicated the approximate location of Wernicke's area. And by the way, I hope you'll be able to attend later this morning the oral session on language where Dr. Catani and his colleagues will be presenting new investigations on the functionality of these pathways. This organization can be diagrammed in this fashion. So Wernicke's area is connected with Broca's area through the arcuate and with the anterior temporal lobe through the inferior longitudinal fasciculus. But then there is a set of very important and often overlooked pathways which originate in cortices posterior to Wernicke's area. These pathways run deep under Wernicke's area without necessarily synapsing onto neurons of Wernicke's area as they go towards the anterior language pathways. Now, this arrangement has very important implications when you keep in mind that virtually all cases of Wernicke's aphasia in the literature are based on patients with cerebrovascular lesions, and that cerebrovascular lesions and neurodegenerative diseases have distinctly different habits. So let's assume that there is a patient with a stroke in Wernicke's area. So this will destroy neurons here and cause an impairment of repetition. And the trivial outcome of this is to disconnect Wernicke's area from Broca's area and the anterior temporal lobe. But cerebrovascular lesions have this nasty tendency to destroy deep white matter bundles. So this would further disconnect the anterior language areas from otherwise intact posterior cortices. So the resultant double disconnection of Broca's area will cause decreased sentence comprehension. The double disconnection of the anterior temporal lobe will interfere with naming and single word comprehension. So the outcome will be the full-fledged Wernicke's aphasia with poor repetition, poor sentence comprehension, poor word comprehension, poor naming. Let's see what happens if there's a neurodegenerative disease killing neurons in Wernicke's area. So this would interfere with repetition, but neurodegenerative disease don't have a primary destructive effect on deep white matter bundles. So there would be only a partial disconnection of Broca's area, which would give rise to variable sentence comprehension performance, and a partial disconnection of the anterior temporal lobe that would be sufficient to interfere with naming, but not with single word comprehension. And the result would be a logopenic primary progressive aphasia with poor repetition but intact comprehension. And let me illustrate this with two of my patients. So this is a patient with obstruction, with occlusion of the angular branch of the middle cerebral artery, and you see this almost cystic lesion in Wernicke's area. And this patient had a complete Wernicke's aphasia with poor comprehension. Here is a patient with a neurodegenerative disease affecting Wernicke's area, in fact, causing cortical loss even more than the infarct, but this patient had a logopenic aphasia with poor repetition but intact comprehension. The big difference is deep white matter. You see that here there is an infarction of deep white matter disconnecting otherwise intact posterior cortices from anterior language areas. No such deep white matter infarction in this patient. So I would like to suggest that Wernicke's cortex is not all that critical for sentence or word comprehension, but that Wernicke's region is critical for these functions due to its strategic location at the confluence of major pathways. Now, the one aspect of this organization which is the most difficult to reconcile with classic aphasiology is the importance of the anterior temporal lobe for single word comprehension. So let me try to illustrate this with the help of a short patient video.
Are you having any difficulties at all?
You know, I'm really not. I live in a really nice house, and I've pretty much trained my husband to do what I want him to do, and he's pretty good at it.
Let me ask you some questions.
Okay.
Do you think that virtuous people in this world are likely to be rewarded?
Not necessarily. I think that people who love God are the ones who will be rewarded.
Yes. But what if someone violates someone's trust? Do you think they should be punished?
Yes, but I think you need to be a giver of grace.
How about someone who violates one's confidence, are they more likely to be bad people?
That's an interesting question. I think there's a possibility that they're more likely to be bad people, but they may not be bad. They may not be.
Okay. Do you think that it's possible for an asparagus to eat a mouse?
Yeah.
And how would that happen?
Well, if he saw one on the ground and it was available to him, he'd probably go eat it.
And do people wear lemons on their heads?
No.
Why not?
Well, it just doesn't look good.
But do some people wear lemons or pumpkins on their head?
Actually, I have seen some people do that. They did it over the holidays, but I wouldn't do it.
If you were to see a spatula eating a lion, what would you think?
Well, probably the first thing I'd do is try to run up and grab it, get it from happening.
Yes. And how would you do that?
Well, that would be hard. I'm not really sure how I could do that.
And how does a spatula eat a lion? How does it do that?
How does a spatula eat a lion? Actually, the lion's the one that really eats the spatula.
Do they eat spatulas?
Mm-hmm.
Yes. Do they like spatulas?
Yeah, they do.
Yes. And what do you think? Are lions more likely to eat spatulas or meat, for example?
Probably more likely to eat spatulas, I would guess. I mean, I don't know.
Okay.
We have some in our outside our yard.
Okay, that's fine. Okay, Jeff.
So, here's a patient who is perfectly fluent and seems to understand conversation where abstract concepts are involved, and yet she has this absolutely unimaginable, almost unbelievable impairment in understanding the meaning of single words that denote concrete entities. Now, at the time that this video was done, she had a pretty focal atrophy on the left anterior temporal lobe, as you can see right here. And it is this linkage of the left anterior temporal lobe to single word comprehension, which is the single most revolutionary contribution that PPA has made to the neurobiology of language. And let me try to explain why. So this is a map of cortical function published by Carl Kleist in 1934. Kleist didn't care much for fMRI or graph theory. He investigated soldiers who had sustained focal shrapnel wounds to the head in the trenches of World War I. And let's see what he concludes about the superior temporal gyrus. And here you may be able to read, here's an area for sentence understanding. Here is an area for word understanding. So really, this is very close to the classic notion of Wernicke's area, which is not surprising because bullet wounds would also destroy deep white matter bundles in this area. And as you can see, just about every nook and cranny of the cortical surface is given a serious, important job to do. The one exception is the tip of the temporal lobe. This area doesn't seem to have any functional portfolio whatsoever, and it is indicated only by this Brodmann architectonic number. And in fact, classical physiology for 150 years had nothing to say about the anterior temporal lobe, either good or bad, probably because this area is not vulnerable to focal cerebrovascular lesions. This silence at the tip of the temporal lobe was broken in the 1990s when John Hodges and his colleagues linked the comprehension impairment in semantic dementia to damage in this region. So in the 1990s, when it seemed that the language network was on the verge of getting a new recruit, this part of the brain was reconceptualized as an amodal hub for general semantic knowledge. Now, if this is correct, then the single word comprehension impairment you saw on the tape could represent a collateral outcome of a general semantic impairment, so there would be no justification to confine the specialization of this area to the narrow domain of language. This is a question that my colleagues and I addressed in a series of experiments, and I have time to show you only one of these. This experiment had two formats, a verbal and a nonverbal. So these are all on patients with focal left anterior temporal lobe atrophy. The subject would see a prime, which is a picture of an object. Then 200 milliseconds later, there would be a probe. This would be a single word on a television screen. The word could be a match. In other words, it could be the name of the object, or a semantically related or semantically unrelated mismatch, and the response would be either a yes or a no. In the nonverbal format, both the prime and the probe were pictures. So the probe could be a match, in other words, another example of the same object, or a semantically related or unrelated mismatch, and same kind of response was required. And these are the accuracy results. The blue bars indicate the performance of control subjects. The red bars are patients with PPA, semantic PPA, with focal left anterior temporal lobe atrophy. And you can see that in the nonverbal format, there is no impairment. In the verbal format, there are impairments in accuracy. The patient is less accurate in identifying a match. In other words, they can't recognize the noun as being the name of the object they see. And there is this very interesting dissociation where they are much less accurate in identifying the semantically related than unrelated mismatch. This is a manifestation of what is known as taxonomic interference, and it's an important mechanism for the comprehension impairment that we see in these patients. So it seems as if the left anterior temporal lobe is not indifferent to cognitive domain, and that it has a functionality that's sort of polarized towards the processing of verbal material. And this conclusion is supported by this experiment on resting state connectivity in neurologically intact subjects. When we put a seed in the left anterior temporal lobe, we find significant connections with the two other major components of the language network, Broca's area and Wernicke's area, and to a lesser extent, homologous regions in the right hemisphere. But when we put the same seed in the right anterior temporal lobe in the homologous polar region, then at the level of significance we chose, we do not see the same significant connections. So I think all of this supports the conclusion that the left anterior temporal lobe should be inserted into the language network as a third major hub with a critical role in single word comprehension. The part of the anterior temporal lobe that's critical for comprehension extends all the way into the pole, and the pole is a very interesting region. This is a summary of work done in my neuroanatomy laboratories using axonally transported tracers in the brain of the macaque. And this work led to the conclusion that the dorsolateral part of the temporal pole in the macaque contains a downstream node of auditory association pathways, that the ventrolateral part contains a downstream node in visual association pathways, and that in between there is transmodal cortex for multimodal integration. But the medial part of the temporal pole is entirely dedicated to olfactory and limbic functions. So you may wonder how it is possible for an area with such strong limbic affiliations to play a major role in what is probably the single most non-limbic function of all, namely language. And the answer, of course, is phylogeny. The macaque and human brains parted ways 25 million years ago. And even though evolution moves slowly, 25 million years is a long time. These are coronal sections from equivalent regions of the macaque and human brains, macaque on the left. And here underneath, photomicrographs or cytoarchitecture in the regions underlying this red star. And now let's first look at the macaque. Now, those of you who are initiated into mysteries of cytoarchitecture may be able to identify this hyperchromic appearance of layer 2. So intensely staining, hyperchromic. This is a marker of limbic lineage. Under this layer 2, you see this collection of robust, healthy, eager neurons, but they have very little columnar or laminar organization. Let's take a look now at the equivalent region of human temporal pole. First, layer 2 is no longer hyperchromic. Secondly, there's a beautiful granular layer 4. And thirdly, there's this gorgeous columnar organization of pyramidal neurons going all the way from layer 3A down to 5B. This is the appearance of the highest level of differentiation of association cortex, the likes of which you only see in posterior parietal and prefrontal cortex. This means that architecturally, the temporal pole of the human brain has the computational power to deal with any cognitive task you can throw at it. In the left side, this computational power is polarized towards linking sensory word forms to their distributed associations that collectively encode the meaning of the word. This is why when you have a lesion on the left, you see impaired word comprehension. In the right side of the brain, the temporal pole is polarized towards linking object percepts to the distributed associations that allow the experiential recognition of the object, regardless of whether it can be named or not. So damage there gives rise to associative object agnosia. And it is only when the temporal pole is impaired bilaterally that you have an amodal impairment that is called semantic dementia. So semantic dementia and semantic PPA and object associative agnosia are different syndromes with different anatomies. So that's really the time that I have, and let me leave you with a few take-home messages. Neuronal loss in Wernicke's area is not sufficient to cause Wernicke's aphasia. Instead, it causes a logopenic aphasia. Secondly, Wernicke's aphasia reflects the combined destruction of cortex and underlying fibers of passage through Wernicke's region. Third, word and sentence comprehension are dissociated functions. Fourth, Wernicke's area, i.e. the temporoparietal junction of the left hemisphere, is critical for phonological loop function. And five, the left anterior temporal lobe needs to be included in the language network as a domain selective rather than a modal hub. I have titled these conclusions as tentative principally because they derive from a single patient population. The first golden age of cognitive neuroscience revolved around patients with focal cerebrovascular, traumatic, surgical lesions, and led to principles, many of which are still valid. It's fair to say that cognitive neuroscience is now enjoying a second golden era, revolving around focal neurodegenerative diseases and really miracles of imaging spearheaded by the OHBM community. And these approaches, as I hope I've been able to show you, are leading to a slightly different perspective of behavioral anatomy. The prudent cognitive neuroscientists should avoid the temptation to assume that these different perspectives are alternate truths. Instead, the goal should be to integrate as many perspectives as possible by resolving inconsistencies in a principled, mechanistic way and identifying as many convergences as possible so that we can maintain our sanity as we try to figure out how the brain is doing all these things it's supposed to be doing. So let me conclude by thanking all my colleagues in Chicago who have done the work that I have outlined for you and who, as you can see, utterly enjoy what they are doing. Thank you.
So Marsel was, first of all, an incredible tour de force spanning centuries and different lobes, and really remarkable. Has also finished ahead of time, which is amazing because I introduced him late. So we have time for, let's say, 2 or 3 questions.
Hi, Marsel. That was
Steve. Yeah.
fabulous synthesis. I really loved it. One thing I thought of when I was listening to your patient talking is, why do people with anterior temporal lobectomy not behave like she behaved?
Excellent question. So this is a question that is often asked. So it has prompted me to do a little literature search. And I think the answer is in the selection of patients. So if you only look at those patients with temporal lobectomy who, because of seizures, who have absolutely no structural MR lesions, no hamartoma, no migration impairments in cortex. Number two, who have onset of seizures in adulthood after the acquisition of language. And number three, who have proven left hemisphere dominance of language. Then you look at those lobectomies, and there is significant language impairment, both in naming and in comprehension. So it's only when you look at the entire set where there is a rewiring of the brain for many different reasons where this is not seen. But it is a very interesting objection that could be raised to this formulation, and one that I think really deserves to be looked at very closely.
Having had hundreds of patients awake during surgery, the one area that I've noticed that also causes semantic problems is the insular junction. And the only anatomic tract that we see running through that area is the IFOF, which we've been hypothesizing plays a role in it. So can you comment on what might be running through there that could be playing a role in the semantic system? Because we note that we've all noted this.
It's a very interesting question. I really don't have an answer for that, but I wish you would come up with additional information on that. Yeah.
Hi, thank you for the talk. That was awesome. I was just wondering about mixed transcortical aphasia or isolation aphasia, where just the language network is isolated from the rest of the brain, and the most common symptom you see is echolalia, where they can only repeat versus not being able to repeat, which is common in most perisylvian conditions. So I was wondering if you could just comment on that condition and how it might play into this model of primary progressive aphasia that you presented.
Yes, thank you. I think in the transcortical, double transcortical aphasia or isolation of the language area, then this echolalia simply shows that the repetition mechanism is intact, not only intact, but it's hyperactive because it's not being held in check by anything else. And so we would expect all other functions, including anterior temporal lobe function, to be impaired because all the information getting there is being interrupted.
Avi, in the back?
Yeah, that's a wonderful talk. Do you know if there is a well-defined syndrome resulting from section of the left uncinate fasciculus and theory to account for it?
Again, another excellent question. I really wouldn't want to comment on this. As you know, the literature on conduction aphasia is contentious, and the original Lichtheim formulation was that this was caused by an arcuate fasciculus lesion. Since then, there have been a lot of additional information, including many intermediate regions in the supramarginal gyrus, temporoparietal junction, that play a role that may be related to the arcuate fasciculus, maybe not related to the arcuate fasciculus. I was interested in the role of insula in this function years ago, and so I really don't have anything further to say about that question.
All right. So let's thank Marsel again, and we'll move on to the oral sessions.